My dear students, in this small video, I am going to discuss about Mottling score and its importance with regard to the resuscitation targets in a patient with sepsis and septic shock. Now, what is this Mottling score? This Mottling score is a bedside clinical tool that assesses cutaneous microcirculatory perfusion. We know that skin is richly supplied with capillaries, and a fall in the microcirculation will be depicted easily from the skin, and it can be picked up to find its extent and severity based on its affection in the skin. This is particularly important in septic shock. Now, this mottling score is evaluated around the knee region, as you can see in this image, where it has been graded from 0 to 5 based on the extent of skin mottling. If you see there is no mottling, obviously it is 0. But when it is small mottling area over the knee, it is 1. Mottling not exceeding the upper border of the patella is 2. Mottling extending above the patella to the mid thigh is 3. Mottling up to the upper thigh is 4. And severe mottling beyond groin is 5. As you can see in this picture, there are two pictures showing a score of 2 and 4 according to this definition. Now, higher the score, worse is the microcirculatory perfusion and higher the mortality risk. Therefore, the scores reflects microvascular failure, which often persists despite normalization of the macrocirculatory parameters like the mean arterial pressure, lactate, etc. Now, this was first discussed in 2011 in intensive care medicine, and the same authors, Aufela, had also published another study in the same year to see its effect on the. In 2013, they had published another study in microcirculatory failure in non-sepsis patients. Now, in this study, in mottling score predicts survival in septic shock. They said that this mottling score is reproducible and easy to evaluate at the bedside, and the mottling score, as well as its variation during resuscitation, is a strong predictor of 14-day survival in patients with septic shock. Now, another study was published by Kazude in Critical Care in 2019 to see the relationship of mottling score, skin circulatory perfusion indices, and biomarkers of endothelial dysfunction in patients with septic shock. And here also, they could closely relate that higher mottling scores were associated with lower microcirculatory oxygen saturation, but with significant overlap between the scores. Microcirculatory oxygen saturation is a quantitative measure of the peripheral oxygenation and is more specific than the mottling score in predicting 28-day mortality. But yet, mottling score undoubtedly improved the assessment, the risks prognostication of the patients who apparently had a normal blood pressure and were being resuscitated. Let us go through a few cases and understand it better. A 62-year-old male of urosepsis presents with a MAP of 58, a lactate of 4.8, capillary refill time of 5 seconds, and a mottling score of 3. Now, the interpretation is there that macrodynamics, macrohemodynamics, and microcirculation are both compromised. And a mottling score of more than 2 indicates significant microcirculatory hypoperfusion. So in this patient, using the resuscitation approach, fluid resuscitation with 30 mL per kg of crystalloids and early norepinephrine, dynamic fluid responsive assessment was performed, and supposing that there is a reassessment of the mottling score every 30 to 60 minutes. And after resuscitation, it is seen that the MAP, which was 58 after 2 hours, becomes 70. The lactate from 4.8 comes down to 3.5, and the mottling score from 3 comes down to 1. So the interpretation is that improvement in mottling suggests improved microcirculation, and which indicates adequate resuscitation trajectory. Let us see the case 2, a 55-year-old female with septic shock due to pneumonia with a MAP of 70 on norepinephrine, has a lactate of 3.2 and a mottling score of very high of 4. Now, the clinical dilemma is that macrocirculation appears acceptable, although it is high, but still it is 70 on norepinephrine, but Mottling score is very high, which indicates persistent microcirculatory failure. And the possible causes in this case would be excess vasoconstriction, persistent sepsis, microvascular thrombosis, as well as inadequate cardiac output. So the underlying management strategy should include cardiac output monitoring, reduce excessive vasopressor dose if possible, because excess vasoconstriction is the one which is responsible here. Inodilators in place of pure vasopressors like dobutamine, optimizing with hemoglobin as well as the source control. So a high mottling score despite BAP normalization indicates occult hypoperfusion. Let us come to this case, a 70-year-old septic shock, initial mottling score of 4 at 0 hours with a MAP of 55, lactate of 5.2 and a mottling of 4. At 2 hours becomes MAP of 65, lactate of 4.1, mottling of 3. 6 hours, 70, 3.2 and 2. And at 12 hours, 72 MAP, 2.1 lactate and 1 mottling score. So here the interpretation would be that there is progressive improvement in mottling score, which correlates well with survival, and a persistence of mottling score of more than 3 after 6 hours is associated with a mortality of around 70 to 80%, which is considerably high. So in this patient, the mottling score has fallen from 4 to 1 and beyond 6 hours. So here the mortality is not expected to be high. Why mottling score is useful in resuscitation? Because this score reflects microcirculation. Traditional targets assess macrocirculation, but shock is fundamentally a microcirculatory disease. It has a strong prognostic indicator with a higher mottling score indicating higher mortality. With 0 to 1 score, it is around 10%, 2 to 3, it is 35 to 40%. With 4 to 5 score, it reaches as high as 70 to 80%. And also because it is simple bedside tool, no equipment is required. Quite similar to capillary refill time assessment, where also we don't require any equipment. Similarly, mottling score is also very easy to do. Integrating mottling into the resuscitation targets, in the first step, we have to target a MAP of more than 65, lactate clearance, CRT less than 3, and mottling of less than equal to 2. If there is persistent mottling of more than 3, we have to evaluate for low cardiac output, excess vasopressors, ongoing sepsis, and microthrombosis. And in step 3, we have to escalate. Possible abscess would be dobutamine, vasopressor titration, blood transfusion if needed, along with source control. So my take-home message would be mottling score reflects cutaneous microcirculatory perfusion. A score of more than equal to 3 after 6 hours predicts high mortality. It may reveal occult hypoperfusion even when the mean arterial pressure is normal. Improvement in mottling is a marker of successful resuscitation, and it can complement capillary refill time guided resuscitation. Thank you very much.